My name's Jeff. I'm a fourth-year medical student. So today, the topic is, does it hurt when I do this? So an expansion on the history and physical exam. So the objectives that I wanted to go through today, I just wanted to go through a quick intro, we'll expand on history taking, we'll go over some physical exam techniques, I'll get a volunteer to do that, and then we'll wrap it all up. So, I am a firm believer that the history is the most important tool in any healthcare provider's arsenal. You can pretty much figure out anything that you need to know about the patient's issue just from talking to them. Like, you'd be surprised just how many questions you can ask and the information that they'd be willing to give you or that they will give you. Like, some people might think that this may be insignificant, and it turns out that is the key to what's going on with them. And the physical exam is much more than just listen to 2 to 4 long sounds. In the back of the bus, what we use our stethoscopes for most is long sounds, but you can use them for so much more. And there's just more than just putting your scope on someone. Look, listen, touch them. Like one of the best advices I was given, actually I'll tell that one later, but so we want to use all your senses, except taste, to the max. Everything that, as a disclaimer, everything that's going to be taught today is just, this is information based. I don't want any of you going out like doing something that you're not trained to do. Like, I don't want you listening to a heart sound and you say, oh, he has like an S4, and it turns out he's fine. Next, please. So, playing House MD, patient history, and why limit your questions to just OPQRST? So, sample and OPQRST, they're good starts. They're very good for what we use in the field to get whatever like the quick things that we need to get out of the way. But there's more you can ask. It's very incomplete. I was telling Scott that everything that we're taught in the EMT school is for patients that are like on the fly, that need to go right then and there. But how many times here have you just had a patient who's feeling under the weather, not feeling too good? You don't need to just like pick them up and run. You can stick around, see what's going on, ask them some questions. That's what I'm trying to get here, is to ask some more questions that might be able to help you and the subsequent care team at the hospital. So a quick recap for OPQRST, it's mainly used for pain. However, what happens if that's not the problem? Like, what happens if pain's not the problem? OPQRST doesn't really work. Sure, you could change it to intensity, as Scott mentioned. I mean, you can change the intensity, say if there's like respiratory issue, but there's no pain. You could probably change it around a bit, but on the fly, how often are like new providers going to think of that? Breaking down sample, we have signs and symptoms, allergies, meds, pertinent past medical history, last oral intake, and the events leading up to the issue. So it's concise. It's useful for when we have patients who we need to get up and go. For patients who we don't know what happened, we need to find it out quickly. This can help. But it does overlook some key points that are ignored. Some of them are surgery, any past surgeries, what's their social history, including their drug history and alcohol use, any traumas in the past that they've had, hospitalizations, and the review systems, which is by far my favorite go-to tool in the history. Next, please. So this is an alternative. This is how I write my notes in the hospital. This is how I take histories in the hospital. And this is how most doctors are taught. Start with your chief complaint. That's the first thing on your list always, because that's going to tell you like what's the patient's actual problem. Like, what do they complain? They can have 15 million things going on. They can just say like, I'm blinking too much. That's their chief complaint. Fine. HPI, the history of the present issue. So the mnemonic I use is Pam hits rub false. So going through that, previous episodes of the chief complaint. The patient has respiratory distress. Say, has this happened before? How many times has this happened before? Allergies, medications, past hospitalizations will also tell you a lot, especially for respiratory distress patients like asthmatic patients. They tell you, oh yeah, I've been hospitalized before, I've been in an ICU, I've had to be tubed before, I've been on steroids. Those are important, these are important things that that doctors and nurses need to know in the hospital and will also help your care. You have a patient who's having an asthma attack, and he's like, yeah, I've had to be tubed twice because of this before. So maybe you'll be a little bit more aggressive. Maybe you'll call up medical call med control, say, hey, I need Solumentrol. This guy's been tubed before for an asthma attack. I don't want to, and he looks pretty bad. Illnesses, traumas, surgeries. Surgeries especially. I can't tell you how many patients I've had here where they have abdominal trouble, and it's been oh, I had like my gallbladder removed a week ago. Okay, fine, you've got small bowel obstruction. That's what's going on. Review systems. These are a series of closed-ended head-to-toe questions. Now, the difference between closed-ended and open-ended questions. Open-ended questions are just like, how are you feeling? What's going on? Closed-ended are the ones that we usually ask in the field, like, do you have chest pain? Do you have shortness of breath? Do you have any leg pain? These ones, so this is the best tool, I believe, for just covering yourself and making sure you've asked everything. So start from head to toe. You just go like, you have any headache, any dizziness, trouble with your vision, trouble with swallowing, any shortness of breath, chest pain, any troubles digesting food, any problems going to the bathroom, any blood in your urine or stool, any problems moving around, sleeping, rashes. That literally was just within 15 seconds. I just did a quick head to toe questions. And patients ask these, and patients answer these, and sometimes they don't even think of it. You say, "Oh, by the way, yeah, I didn't know, like I do have like a bit of blurry vision, like now and then in my left eye." Urinary, GI, family history, which is also important. Going back to the asthmatic patient, patient's like in respiratory distress, and he's like, "Yeah, my mother and my father both have asthma." That helps you. OBGYN, you can ask
last menstrual period.
Yeah, that's the big one. Last menstrual period is huge. Last menstrual period, when's the last time you got checked up? Any STIs? That also ties into sexual history. Any history of STIs? Ask these questions if like the case like requires it. If your patient's having chest pain, you're not going to ask like, so how's your sex life? Social history. This is huge too. This is tobacco, alcohol, drugs, and work. Where do they work? Any exposure? Like, do they go hiking and they've got like heart problems like 4 weeks later? Like, that's a huge red flag. And you travel anywhere, now they're coming back with like massive diarrhea. So once again, this is only a template. This is a template that I use personally, and ask the relevant questions. If you have a patient with respiratory distress, fix them first and focus on a few of these, but like you won't need to ask that patient about like when was their last menstrual period. Do you use a condom? You don't need to ask those. Just like be smart about the questions you like. Ask as many questions as you want, but be smart about the questions that you're asking. So physical exam, EMS gone wild. My favorite quote from one of my EMT instructors in Binghamton, "Go home and touch each other," was the best advice I ever had because it led to great physical exams. Next. So, decap BTLS is lazy. It is very, very lazy. I hate it when people I've seen it happen. I've everyone's seen like the one brand new EMT run on the scene, wave his hands in the air and go BSI scene safety. I've seen someone touch someone's head and go negative decap BTLS. But I hit them when they do that. So, you want to examine the whole organ system, not just the organ. Your patient's having respiratory trouble, don't just listen to their lung sounds. There's so much more that can be affected by someone who's having trouble breathing. You're missing lots of signs when you're just focusing on the main organ. As I said, you want to check what else is affected, and because you have to think about where does that organ system lead to. Especially let's go with cardiovascular. That goes everywhere. Heart's here, your vessels go everywhere. So if your patient's having chest pain, or they're having, they've been having like a wet cough, or they've been feeling very tired, you suspect that it could be something wrong with their heart. Check their vessels too. It's called the cardiovascular system for a reason. Look, listen, feel is the big boy term for that is inspect, auscultate, and palpate everything. Always, whenever you're checking any organ system, do those three things minimum. And a good physical exam, checking multiple organ systems, can be done in 5 minutes flat. Those going to med school or in med school know that the clinical skills exam, where we have 12 patients and we need to do a history and a physical within 15 minutes. So, yeah.
12 patients?
And 12 patients. And each of the patients have to be done in 15 minutes, and then you have another 10 minutes to write a patient note, a full patient note with a plan of action and what tests you want to do. That exam, if you take a good history is 8 minutes. That leaves another 5 to 7 minutes to get a good physical exam in there. And half of these patients that I had when I took my exam were not just like, I have chest pain. They're like, oh, by the way, I'm peeing blood. Oh, by the way, I've been fainting now and then. Oh, by the way, I can't feel my left foot. So imagine I have to do like 4 or 5 different physicals in 5 minutes. So a good physical exam where you can like go through everything can be done in 5 minutes. It is very possible. If you see something, say something. Do not keep it to yourself. You notice that your patient's sweating, and even though they say, I'm fine. If you're the in charge, tell the nurse. If you're the BLS and your ALS is there, tell your ALS, right, hey, he's sweating. Maybe we should do an EKG. So get in the habit of writing your physical in the narrative. I mean, we've got the power tools, which are brilliant. I love. I don't know why some people hate them. I love them because they have everything right there. But I like to write it down because that way I remember it. So you check the patient head to toe. Write it down from head to toe. So here's a template for my physical exam that I write. So I go general, like how are they looking? This is like when you like walk in, you assess the patient. You see, oh, so 20-year-old female sitting comfortably, no apparent distress. That would be for general. Heat, or dot. What's heat?
Don't know.
Heat is head, ears, eyes, nose, throat. So that's like you want to talk about everything from like the neck up. Throat out. Neck and shoulder, talk about what's going on there. Cardiovascular, rest, abdomen, extremities, and neural last. So you can write, I like to write negatives and positives. So if a patient like they have trouble breathing, but they don't have like cyanosis of the lips, you can write in apparent distress, like labored breathing, no central cyanosis noted, no like clumping of the fingers noted. Next. All right, hands-on practice. I need a volunteer. Let's go. Thank you. So we're gonna go over 2, maybe 3. Yeah, we'll do cardio first. So this is more for ALS providers, but I believe everyone should be able to listen to 1 to 2 heart sounds because it's useful. It's at the very least to just say that everything's there. So when we go look, listen, feel. So when you would think a cardio exam, inspecting, auscultating, and palpating, you just look at the chest. You also look at the face. The patient is a patient red in the face. So they like obviously distressed. Do they have central cyanosis of the lips? Any flushing? Any sweating? Look at their eyes. Are they equal and reactive? Look at their neck. Do you notice any like bulging of the veins? Do you notice any scars? Any pulsations? Then you look at the chest. Do you notice any scars? Any pulsations? Any asymmetry? And then look at their hands. Do you notice that the patient's hands are they clubbed? Is the capillary feel good? Are the palms very red? And are there peripheral pulses on the radial side? Then auscultate, listening to lung sounds. Does anyone have a scope on that? No? Okay. So this, once again, this is for information purposes only. We like to listen to 4 areas for the heart sounds. The aortic area, which is right over here, pulmonic area over here, tricuspid over here, and then mitral right over here. Each area is you're listening to a different valve within the heart. So I like to, whenever you listen to a heart sound, normally you hear 2 sounds, a love dub, S1 and S2. So you should be able to hear an S1 and S2 here, and check S1, S2 here. If you can hear both of those, then you're fine. If you're hearing something extra, note it down, tell the nurse. Next, going for rest. Once again, 2 to 4 lung sounds aren't enough. I like to do you'd be surprised. Like, there's a book called Bates Guide to Physical Exam. This is like the Bible of physical exams. They say listen to 14 lung sounds on either side. So a total of 28 lung sounds. We're not doing that. I like to say listen to 4 to 6 on both front and back. You should be listening front and back because there are anterior and posterior lobes of the lung. So 1, 2, 3, 4, 5, because you have a middle lobe which goes around the right on the right side, and 6, because the left does not have a middle lobe. And then, lean forward please. Same thing on the back. Listen, 1, 2, 3, 4, 5, and 6. That's for auscultating. Inspecting and palpating, you want to look for the same thing. You all, once again, you want to look at the face. Do you notice any cyanosis of the lips? Do you notice any labored breathing? Are they bent over, tripoding? Look at the hands. Do you notice any clubbing of the fingers? Do you notice any cyanosis of the nail beds? Look at the patient just as a whole. How is he sitting? He's sitting upright. He's not hunched over. He's not in any signs of obvious distress. You look at you can see like the clavicle muscles. You can see the muscles of his neck. He's not using those to help him breathe. Look at his abdomen. He's not using his abdomen muscles to help him breathe. That's telling you a lot about how this patient is. Ask him, what's your name? If he speaks in one clear sentence, it's okay. If he's like taking a breath in between every word, that's an issue too. So these are all just little signs that you can just take in and notice. Document them, and they will point you to whatever's going on. Quickly, I want to do a neuro exam, but I want to do a cranial nerve exam just because I think it's really cool and it's really quick. So the cranial nerves are nerves that come directly from your brain. We like to look at, instead of 1 through 12, I like to look at 2 through 12. Number 1 is your sense of smell. Number 2 is how your eyes actually, like your vision, you're actually just your vision itself. So that's where you check with your check pupils. If both pupils are constricting, and then 2 is fine. 3, 4, and 6 have to do with eye movement. So follow my finger. Do a big H movement only with your eyes. Just go forward for a combination. Yeah. Like I have, your syphilis patients. If you bring it closer, they don't go cross-eyed. They just stay the same. They stay. So that's 3, 4, and 6. Number 5 has to do with tactile, like your face and head right over here. So you would say, like, close your eyes. Can you feel this equally on either side? Yes. Okay. Open your eyes. Now we have, actually close your eyes again. 7. Keep your eyes closed. Try to open, and if they try to open your eyes, but don't let me. If they can't, that's good. Number 8, hearing. Can you hear this equally? Yes. Okay. Number 9 and 10, swallow for me. They can swallow just fine. There at the 9 and 10, you can do the gag reflex too. So like we take a little in the hospital, we take a Q-tip and just jab it in there at their tonsil. Or I also like to do just open your mouth, stick out your tongue, and say ah. If their uvula in the middle is like on both sides, if it's like quivering or if it's like deviated to one side, that's a problem. 11, shrug your shoulders. Good. 11's fine, and stick out your tongue. Move it left to right. Number 12 is fine. Those are your 12 cranial nerves. That can be done in 30 seconds. And this also, like, tying into Diana's thing, this is a big thing to check for a stroke patient, because brain bleed, like, maybe not just a stroke, maybe just like a regular brain bleed, or someone having like migraines or TIA too. These things will be affected. So in conclusion, the history is only limited to how many questions you asked, and a complete history won't just help you, but it'll also help the hospital provide better patient care. Tying in once again to Diana's lecture about strokes, like time is muscle with these patients. If you ask the right questions, you do the right physical for a stroke patient, you can get them in within minutes, getting them the CAT scan to figure out what's going on. And with enough practice, a physical exam can tell you a lot about a patient's condition. I was talking to you, I was talking to Frank about it too, with like a patient with having an MI. The one sign that you can't mask in an MI is sweating. Can't be masked by anything. So like we had a patient that same day. We had a patient who just looked like shit. He looked like he was, and he's like, I don't feel so good. I don't know what it is. He was sweating like a mother, and then like his EKG was a bit normal, but I think it turned out to be an NSTEMI. So we saved that guy. And don't be afraid to expose your patient in the ambulance. Like we say, like on the one hand, we learn in EMT school, like go out, like get used to touching people. Also get used to having them like exposed and like naked in front of you to do your like see what you need to see, feel what you need to feel to get whatever information you need to help this patient out. Because in the end, this is what it is. We are saving lives here. So you need every tool you can get, and these are the two most basic yet most effective tools that you have. Any questions?
My question is, what is your position on the 13th cranial nerve?
Oh wait, I don't have a question, but I do have a statement. Remember you were saying, oh, when they have chest pain, don't worry about the sexual history. My 96-year-old patient was in the hospital for chest pain because she was having sex with her 6-year-old boyfriend.
Nice.
Good for her.
Yes.
I have a question. So, when we giving an oral report to the nurse in the hospital, we obviously can't go through everything. We just ask them and all of that to the nurse. What would you include in that 2-minute or 3-minute oral report that I have to give to the nurse?
For the nurses, I stick with go with chief of complaint, go with the history, what's going on right now, anything pertinent anything that you feel is pertinent to this issue. So if your patient says that he works at McDonald's but he's having a severe asthma attack, you don't need to say he works at McDonald's. Stuff that's pertinent to it. He has a history of asthma. His family history of asthma. He's been intubated before. He's had to have steroids before for his asthma. He's a smoker. stuff like that is good to tell. Anything else? Lovely. Thank you.